So my name is Dr. Joel Fish. I'm a plastic and reconstructive surgeon at the Hospital for Sick Children. And I've been here for more than 12 years. And I've been practicing as a plastic and reconstructive surgeon since 1994. And the thing that drew me to the area of, well, first of all, there's what drew me to medicine. And the reason I became a doctor was to help people, which sounds sort of silly all these years later, but that's still true. And that's why I chose this profession, and I'm glad I did. And then in the journey of sort of figuring out what to do as a physician, which can be very difficult and complicated, I was very lucky, and I was exposed before medical school to the practice of what at that time was a very new development. It was called microsurgery, where they had sewing needles that were basically smaller than what you could see with your eye, and they were using these to reattach fingers and limbs of people that were amputated. So, and this goes into the 80s. And for no real particular reason, I was just fascinated by that. And there was a laboratory here at the Medical Sciences Building at the University of Toronto, and I was lucky enough to get a position there as a summer student. And from there, that's kind of where my interest grew. But in terms of what I do and who I am, I'm a burn surgeon. I specialize in burns, and I've been doing that for more than 20 years. I often say to people, I didn't choose this profession, it chose me, which is common for a lot of people. So I don't practice what people would recognize as a private cosmetic practice. But see, the principles of aesthetics, and the main difference is that when you're dealing with the private public and you're doing aesthetic surgery, which is very common, and there's some amazing practitioners in that area, you're really taking what is like a normal process, often related to aging, and you're actually trying to improve things, right? So that it's a very different view of medicine in the world and what you're achieving. In the area of reconstructive surgery, you're taking people that are either born with congenital defects, acquire congenital defects or tumors or burns, trauma. And so something has been acquired and now you're reconstructing, trying to get back as close to normal as you can. So the real fundamental difference between the two in a sort of a definition is the starting point is very different for both of them. A lot of the things we do is what I identify as reconstructive plastic surgery, where people have been burned, in my case, or other traumas, fractures, tumors and things, is something has happened and now you're trying to use principles and techniques to restore them to make them look as aesthetically pleasing as possible. As really as possible. And a lot of the things that we do as a reconstructive surgeon are really no different than what someone who does, pure cosmetic surgery. Somebody is trying to improve someone with a normal aging face or neck or whatever it is that they're trying to achieve. The principles are the same. The way that you move the tissues are the same. The respect for the anatomy is the same. It's just that the starting point is very different. And so that's really the main differences. I don't practice in the area of aesthetic surgery, but much of what I do is aimed at trying to restore aesthetics, right? So it's not true to say that just because you do reconstructive surgery that you don't practice, the same practices as the aesthetic. The other has the maybe negative connotation that they're private, people are paying for it, you're trying to restore, health and beauty, and it is basically what you make it. But there are a lot of people out there that practice cosmetic surgery in a very ethical, moral framework. They do things for people that help restore their confidence and help them to get back into the world. And so there's a bit of a gray zone there, a bit of a fine line between, what is reconstructive surgery and what is this purely aesthetic or cosmetic surgery. I often will say to people, it's not that much different than they say that the difference between tragedy and comedy at either end, right? Something that's very tragic, people sometimes it causes them to laugh. And it's the same is true of comedy, which is there just for humor, but some comedy is actually quite dark. And so, what is the real difference between them? It's the same thing in reconstructive and aesthetic surgery. Sometimes there's this big gray zone and you don't really know, that you're necessarily practicing one or the other. So I hope I explained that. In the developed world, burns in adults are mostly flame burns, mostly related to occupation or hobbies. Children, the vast majority of the injuries are scald burns from hot liquids, tea, soup, coffee. That comprises like 90% of the injuries in the developed world. Then there are other kinds of burns that happen, electrical burns, chemical burns, quite rare, but we do see those and we treat those. And when you go to the underdeveloped world, the sort of the causes and the outcomes of burns totally shift. And you now start to see a lot more flame burns in children. Children are exposed to open cooking areas, and the areas of safety and prevention are not in place. Electrical burns of children in the developed world are relatively uncommon. We have electricity all over, but we have lots of safety. In underdeveloped areas where they are living in not the best environments and conditions, children get exposed to electrical injury. So the most common are scald or liquids, flame burns, chemical, electrical burns, and then the other burn that happens most commonly is a contact burn. So hot objects. In the developed world, it's children, it's a disease of curiosity, glass-fronted fireplaces, barbecues, all of those things. In adults, it's usually occupational. They're working in an area where there's a very, very hot industrial equipment, and it's usually an accident where they make contact. In the underdeveloped world, so we shouldn't see a lot of contact burns here, but in the underdeveloped countries, contact burns in children are all too common and often sort of devastating injuries. So what you're talking about is a classification of burn depth, and the terminology we use is superficial burns, which just go on to heal on their own, partial thickness burns, which are partially through the skin, the layers of the skin, and then full thickness burns, where the skin has been burned all the way through. Right? Those are the three terms that we use: superficial, partial thickness, and full thickness. And there's two ways that we determine them. One is just looking at the burns and having clinical experience, which is not that accurate early on. We have some technologies. Laser Doppler technology is one of them, which looks at the blood flow in the tissues and is actually more accurate than the human eye. And then there are some research areas that have looked into predicting the depths of burn. Those instruments tend to be cumbersome and expensive. They're not used a lot. The most common way that they're diagnosed is clinical, where somebody has an injury, you provide a dressing, follow them for a week or 10 days, and look for evidence of healing or deeper burns, which then need surgery. And then that's kind of in a word, that's how that's handled. So first of all, when you say burn, so we're talking children or adults. So when in the adult population, and they tend to be a little bit different. The key reasons why adults go and get cared for is a critical area. So face, hands, feet, perineal area, right? Those are difficult areas to treat. And even though there might be a small area like the size of your hand, but that's a pretty bad burn. So critical areas, they need to go. The same is true of children. In adults, small areas, in areas that aren't highly functional, an area on your stomach and an area on your back, sometimes they'll choose to stay to be treated, but there's a lot of misinformation about even the basic care of burns. Children, we have a very low threshold that they need to go to a burn program or at least be consulted to a burn program. Many of the children's burns that happen are scald burns from hot liquids and tea, coffee, etc., as I mentioned. And what you see at time zero often looks not so bad. And then when you look at them 3 to 5 days later, there are huge surprises in terms of how deep they are and what they are. So we have a very low threshold to say that children with scald burns need to be consulted to a burn specialty program so that at least they can be seen. And nowadays, with virtual connections and just taking photographs and sending them on your phone, it's a lot easier to access the care for things like this. So there's a very low threshold in children to send them. And then the end of the answer is any burn in a child that's greater than 10% of their body surface area, they have to go to the hospital and they've got to be seen. That's way too big an area for someone to treat, like a whole area of your chest. And in adults, similarly, burns that are like 10% or greater, you can't buy dressing supplies in a drugstore to cover your whole arm. It'll take your whole wage to do that. You need to go to a burn center, get a proper dressing, proper pain management, etc. That's sort of just like a friendly way of the criteria. And then healthcare providers have very strict criteria that they're supposed to use to access burn care. Pretty low threshold to want to get expert opinion on things. "85% of the burns that we see are under the age of 3. So when the children reach the age of 2 and they start to become toddlers and they're all over the place, their life is all about curiosity and exploration. And so a hot cup of tea or a hot cup of soup with the steam coming off it, it's seen like a plaything, right? And often or just lack of recognition. They have no real self-awareness that if I go toddling over to the stairwell and that I'm going to hurt myself if I fall down 3 stairs. Similarly, they see a cup of tea or coffee and they want some and they grab it and they knock it off counters, which is why we teach children are not to be in the kitchen. We say 3 feet from the heat around fires, 6 feet from the heat, 8 feet from the heat around fires, like you're supposed to be away from them. Kids are not supposed to be around them. Spill-proof mugs, right? If you're an adult, and because you put the cup down and you go, who knows what those kids are going to do. And also, you're not supposed to be holding a child while cooking, and we see this all the time, cup of coffee in one hand, child in the other. It takes a second to change the whole trajectory of that child. 1 second can burn the whole front of the kid, right? 1 cup of tea. If parents knew the devastation that we see in the hospital, 400 to 450 new families a year come in with mostly skull burns, mostly preventable. Most of them happen within a moment and they last a lifetime. Yes, very much so. So first of all, because adults can speak for themselves, you can adjust dressings, you can adjust pain medication, you can have a little bit more of a leeway in terms of the treatments, the care. Adults often need to be admitted to hospital if they have a lot of comorbidities, smoking, peripheral vascular disease, other kinds of things. Maybe they're immobile and they can't handle it. So they're a very different group. Children, of course, we most of the time we sedate them for their care, so we put them asleep, we wash and clean their wounds, and we use dressings that can stay for a week. We don't change dressings every day in children. We've been doing that for years here. It's distressing for the children. It stops the pain and allows them to go home. So children will do anything to keep them home. We use these long-acting dressings, which have been around for a long time, special technology, some of which was developed here in Canada and other parts of the world. And also, we are getting parents to administer pain medication. So the way we do that is a lot different than the adults. We have to sort of structure it differently. It takes a lot more explanation. Parents aren't always sure how to tell if their child's in pain. And the other thing with children that's very different than adults is when you have something bad happen to you and you go to a hospital, you have the pain, but you also have fear and anxiety. In adults, you can often tease the two out and you can speak to them, and often you can tell what is pain, what is anxiety, and you can work on that. Whereas children often have both, and they don't verbalize that. And so dealing with the anxiety in children can sometimes be very tricky because they don't verbalize it the same, and sometimes it looks just like pain. And so people just think it's pain, when in fact it's just fear. So there are two very different things, lots of differences in treating them. At this hospital where I work, the Hospital for Sick Children, we run the pediatric burn program. 85% of the kids are under the age of 3. And the typical is the expectation is that you're going to be either sent from an outside hospital or possibly through our emergency room. We're going to come in and take a picture of your burn, cover it up, and arrange for a sedation so that the child can be put asleep, washed and cleaned with soap and water, and a long-acting dressing applied so that family and that child can be together and they can go home and not stay in the hospital. That's sort of the overall goal for a lot of the burns. There are times when the children and the parents need a little bit more support. They need to be in the hospital, maybe for a couple of days. We try to get them in, get their confidence with giving pain medication, confidence with providing some care for areas that we don't put dressings on, like burns of the face and the neck. We don't wrap them up like in the movies, like mummies. We leave them open and use ointments, and that can be hard for the parents to learn. So the goal is, for those parents, a short visit to the hospital, maybe a couple days, get them confident so that they can leave and go home, back to, familiar bed, familiar food, familiar surroundings. The healing of acute burns, fairly straightforward in terms of the principles. One, when you accidentally scald yourself, say with children, with a liquid, that skin or that leg, 2 minutes before you burned it was not infected, isn't it? But now you're not going to be able to clean it for a couple of days, maybe a week. So, the treatments that we use are, we need to sedate them for pain control, give them pain medication, but sedate them so we can actually properly wash the area. Clean and wash it and put a dressing that that's long acting, and start them on some pain medication. And if we are able to wash it, keep it clean, put a dressing that fights bacteria in the area, keeps it clean, and allows it to heal, get them home and make sure that they're comfortable and not doing too much activity, hopefully we can get these to heal. And typically with acute injuries, any burn that's going to heal in less than 2 weeks is not something we would operate on. Once the burns, if they're of any size, are healing for more than 2 weeks, we then start talking about surgery with the patients. And then that's like the other part of the acute injury. There's a group of them that need some kind of surgery, usually in the form of what we call skin grafting, where we use parts of their skin, a very, very thin shaving of skin, similar to if you've fallen, you scrape the skin off your knee and you put a bandage on it, the skin grows back. We take a shaving of skin that is actually a bit thinner than a piece of paper. It's quite thin and quite uncomfortable, but that's a skin graft. Put a dressing over that so that will heal, and then transfer that skin over to the burned areas that are deeper. So those are kind of like the simple trajectory of like sort of the two ways that acute injuries go in terms of the children. The number one issue that we deal with, if you need surgery, 100% you will have some visible scars. But even when you don't need surgery, sometimes the burns are deep enough when they heal that there'll be scars as well. So in both cases, sort of to the second part of the question, we are following these children for long periods of time for their scars. We provide basic management in the form of massage, moisturizing lotion, keeping them off the internet from magic creams and magic operations that don't exist. There's no cure for scar. A scar is the result of your body's ability to heal. If you don't heal and you can't form a scar, then you won't be alive. So it is a part of our evolution. We do lots of things to try to make the scars softer, less red, less itchy, less noticeable, but there's always a scar. Once there's a scar, there's always a scar. So we spend the second part of our treatment helping the parents and the kids to treat the scars if they're itchy or painful, to make them flatter and softer, and recognize that scars over time, months and years, go through a phase of becoming more noticeable, and then they naturally will regress over time, depending on where they are and lots of variables. But in general, scars will settle down with time. And then we have special therapists here that help with making sure that they still are using the limbs, they get back to sports, occupations, jobs, whether they need a skin graft or they don't need a skin graft. That's our job, and that's a long phase of recovery for those people. Make sure the children are back doing whatever they enjoy. And then comes the sort of the third phase, which is sometimes, we're seeing children that are quite young, so they may be 3 years of age, but now they're 10 years old and they're a competitive gymnast, or they're doing music, or they're doing hobby sports of interest that now they do things with their body that they didn't do when they were 3 years old. And so suddenly now they have scars that are maybe a bit tight, often a little bit tight, or bothering them. And that's when we get into sort of the reconstructive aspects of loosening scars, making them less noticeable, sometimes trying to remove them and replace them with more normal looking tissue. There's a wide range of things that we do. The amount of reconstructive surgery that's done relative to the number of burns is quite low, actually. So if we see 450 new burns a year, I don't know the actual number of kids that wind up getting surgical reconstruction a year because it varies, but it's quite low. I mean, we might only operate on 10 to 20% of the kids with surgery. And of course, there's some we don't operate on that have scars, so whatever that percentage is. And of that number, the amount of surgery that gets done is probably, again, a much smaller percentage. But it's done over a long period of time. From the time they're 3 till the time they're 18 is a pretty long period of time, and their needs change. So we are following lots and lots of families and children for long periods of time, getting different kinds of surgery, usually to loosen tight areas through different kinds of surgical techniques. So nobody has a cure for scars. People all over the world work on this. The most recent change in terms of a technology is the use of lasers. So lasers have been around forever. Light amplification by stimulated emission of radiation. Laser light is a coherent light. It is designed to attack in the case of the body, the wavelength that you dial in will exactly correspond to either the color of the skin or the blood vessels in the skin or the water under the skin or the collagen or proteins in the skin. Like, you can choose different lasers for many different purposes. So lasers have been around forever. Lasers have been used on the skin for a lot of aesthetic purposes, for tattoo removal, for many different medical purposes for long periods of time. It's really only in the last 10 or so years that they've sorted out sort of two specific lasers and then two specific ways of using those lasers that are beneficial for burn scars. Burn scars can be quite hard to treat. They're a lot more aggressive than other kinds of skin conditions. And so that's been the biggest change. We have a laser program that we've introduced here for children. There are other people in Canada now that are starting to do this, but we're really the first pediatric laser scar program for burns. It was donated. We have a major donor, one of our families, who donate money every year. We haven't seen them due to the pandemic for a little while, but it really has a beneficial effect. We did research in the area to show that the therapy works, as have other people in the world. So that's really the newest part. The other things we do: massage, physiotherapy, the use of silicone products, pressure garments. These have been around for a long time, and these are all other things that we use as well. So in terms of burn treatment, it's interesting that you would ask, because in this last 3 or 4 years, there have been two technologies that we have used in some extensive injury. So children with more than 80% of their body surface area burned. So there are two technologies that have been worked on for years, and one of them has only become available in Canada in the last week, but we were allowed to use it through special access through the government. We've used it a couple of times. It's a membrane where you remove all the burned skin, and you put this membrane. It's a 2-layer membrane, and you put it on. The inner layer sticks through vascularizing, so the blood vessels growing up and attaching it, and the outer layer it's like a cellophane. Think of it like cellophane wrap, and it just sits there. And then when you have enough skin to graft, as I described before, on these areas, you peel off the cellophane and you put it on, and this membrane can stay on for months and months. There's other kinds of technology that are similar to this, but this was a game changer. It was developed in Australia, marketed in Europe, and it's available in Canada. And we have done a couple of kids where 100% has saved their life because they don't have enough skin. And we have to, when I was describing about taking a skin graft, we have to retake those areas over and over and over to get enough skin to cover them. So that's one technology. And the other is a group in Laval, Quebec, who have a bioengineering lab where you can take a biopsy, a piece of skin like the size of my little finger, you fly it to them, they take the cells and separate them in such a way and regrow them, and they create a true bilayer of skin. It has both the outer layer and the inner layer of the skin. It's a very special technology to put together. It takes about 6 weeks until they can develop enough pieces each piece is about this big, but enough to cover an area, say that big. It takes about 6 weeks, but that is also life-saving, and it's like living in the future. It's like the true skin grown in the lab, put back on the patient. And we have a patient where we have covered a major amount of their injury just with skin grown in the lab. And the only way we were able to get them to survive was by using this membrane that was in place for months. And so I almost feel like we are living in the future at the moment with some of the new technology, like to save these extensively injured children and adults, actually. They're permanent, right? So once you've sustained a burn, you can't go backwards. And there's a huge amount of social cost, emotional regret on the basis of parents. And they're there forever. And so your question is like, what is the hardest thing? So the hardest thing is that you can't predict how someone's going to do. So there are children that have major burns that go off and they just don't care. They have a way of looking at the world that they have scars, they don't care. They have scars on their back. They get married, they move on, they have partners, they go to school, and it never stops them. And then you have other children that have burns that you might not even notice, where the circumstances or the way that they accommodate to this injury or the way that the parents treat them or whatever it is in their environment, it becomes it's a permanent mark that they live with forever. And it's hard to predict and know who's going to do what. So the outcomes from these injuries are not what you see. And if there's anything I've learned after 25 years of dealing with patients with scars, it doesn't matter what I see, it doesn't matter what you see, it's only what they see. And people will travel 1,000 kilometers to come see you with a scar that's almost not visible, and you'll have other people with scars that are hugely visible and appear to be problematic maybe to some people, and they just don't care, and everything in between. So that is the biggest single issue, is trying to sort out the outcomes of who's going to do what and who you need to do, who you need to fix and who you just need to leave alone. And it's not that easy. And there's no predictors. You can never say, oh, in this case, for sure you're going to do stuff. You never know. And that really remains probably like the biggest challenge in this area. So we follow people for long periods of time. So you have to imagine if you're 2 or 3 years old, and then between the age of 3 and 8, may or may not matter at all, somewhere between the age of 8 and 12, when someone starts to reach early teenagehood and starts to go through puberty, maybe it becomes an issue again, or maybe it doesn't. And then some people go through the teenage years, but now they get into the sort of old, they're a little more mature, and now they're doing things that are really involved, working in restaurants, have hobbies, interests, sports, music, drama, whatever, and something that meant nothing now might mean something 15 years later. And then you start to transition into early adulthood and the whole concept of university and college and occupations. Now it's like a whole other part of their life where sometimes it doesn't matter, and sometimes it does, right? So the ability to follow these people and just to be there to support them can be quite challenging. It's probably the part of our job as a surgeon, which is a technical specialty, which is the most like a family physician, where you're not seeing them for their coughs and colds, but you're seeing them for an issue that's never going to go away. And predicting who is going to need your help when is almost impossible. But for the right person that likes to follow people long term and really get to know them and then be able to offer them a change when they need it, this is a good specialty. If you're looking to just get rid of scars or have miracles or make people that have natural aging and trying to help with that, it's maybe not as good an area to go into because it's slow, it's long term. It can be frustrating because the scars can be hard to work with in difficult areas, and there's no cure for scars. But it's quite rewarding because you're still a physician. You're still helping people, you're helping them long term. You have the added benefit of having learned a surgical specialty where you really can make a difference, and all the efforts that you put in along with a burn team, which I haven't stressed enough, that the other thing about this is you don't practice alone in an office. If you want to practice burns, you're practicing in a team, and you're a member of a team. I'm a member of a team with other people and we all depend on each other. So it's, that's not for everybody. Some people don't want to do that. That's okay. But that's not what I chose, right? That's the biggest challenge in that area. The team itself, we have a small but very dedicated team of burn practitioners here in the hospital. And so we have a social worker. We have a child life are people that help us and help the children and their families normalize the environment. They're there for their procedures. They're there to help them come to the clinic. They're there to help them adjust to the fact that they're in hospital. They're essential for the burn team. We have a social worker because of the long-term consequences. We have a dietitian because with larger burns, the dietary needs are quite specific in terms of high protein and getting families to work along with that. And there's other things that they do as well. We have occupational and physiotherapists that are dedicated, a couple of them that are dedicated to our team, who really get to know the children long-term after their acute injuries. They have scars, regaining mobility. Getting a 4-year-old to do physiotherapy is not easy. These are very specialized rehabilitation specialists in burns. They're specific to rehabilitation in pediatrics and pediatric burns. Even massaging a scar and all the aspects of pressure garments, massage are done by the rehab team, both getting them up out of bed and getting them going, getting them back into their sports and they're enjoying their life and long term, and in between surgeries sometimes they're needed. They do a lot more, but they're also very long term following them. And then we also have a nurse practitioner who's a master's level trained nurse that really runs our program. She sees, treats, and admits patients independently. She gives advice to families at any time of the day or night. She's always there to fight for the children and the families to make sure they have proper pain control, that their wound care is done properly, and sort of sets the standard for the whole team in terms of the acute injury to make sure that we're on top of these families and helping them through. That's just and then sort of last are the 2 burn surgeons. There's 2 burn surgeons on our team who, our surgical specialty are the burns, but we're also, a lot of our jobs overlap with the other members of the team. We're all responsible for keeping the patients comfortable and getting them in and getting them out of hospital as soon as we can. There are other people that we work with, but those are sort of like the core team members. The only other member that maybe it's not day to day, but we also have a full-time researcher. We have a researcher who attends our rounds to make sure that the research we do in the area of burns is relevant, right? That it's something relevant to what we're really doing. Look after all our summer students and all kinds of things like that. And so that's kind of like the core team. And then we're at any one point in time, we are training fellows and residents that come here to learn about pediatric plastic surgery, and they spend time with the burn team, and then for a period of time they're with us as well. Those are kind of the core team members. There's other people we work with, but those are more like intermittent. There's a number of things. So parents don't like to give narcotics to their children. Narcotics like morphine are needed for acute burn pain, and parents are very hesitant to use narcotics. We use them for very short periods of time. They're quite safe. The kids don't get addicted, but there's a lot of misinformation about that. That's one thing. And also, they're often very hesitant because you see the way children behave or can behave when they're in pain. An adult will jump around the room and they'll tell you, oh my God, my pain is a 7 out of 10. I can't stand it on my foot. And you can talk to them. A child, especially when they're young, will just sit there and not move. And often we'll get told, oh, I don't know, they look comfortable, they're just lying in bed and they don't look like they're in pain. The parent sees this, they think their kid's not in pain. When children are in pain, they lie very still. They'll lie there deathly afraid and not moving. And parents are often afraid to sedate them because we have to give them like anesthetic agents to knock them out so that we can comfortably clean the skin, get all the bacteria off, put on a proper dressing. And the moment they hear that they're having like an anesthetic, they're, oh my God, I don't want my child to have an anesthetic. We have a 9-month-old at the moment. We've had 6 weeks old, 4 weeks old, and we have to give them an anesthetic. You can't wipe a burn in an awake child and have them screaming. The reason that we don't ever do that, and to answer your question, parents are hesitant, is that if you treat the burn and you have to give them a number of sedations until they're better, it can lead to post-traumatic stress disorder and avoidance of healthcare because of this painful experience week after week for 4 weeks. They went in and someone took off their dressings and washed their wounds while they were awake screaming. So the two things parents are very hesitant about, the use of narcotics and the sedation, but we are adamant your kid is going to be out of pain when we do this. And then parents are not so much hesitant, but they really don't understand when you tell them that scars can't be gone, that there's no cure for them. They sort of don't necessarily believe it's true, and they're constantly on the internet, and everyone has a miracle cure for putting things on burns and doing things. Some of them are expensive, useless, occasionally a little bit harmful, and kind of misleading. So that's not necessarily what you asked, but it's kind of in the same area.